disparities in cancer care that existing around the world. People in certain regions, socio-economic backgrounds and marginalized communities often face significant barriers to accessing the quality care, prevention, diagnosis and treatment. These barriers can include lack of access to healthcare facilities, financial constraints, stigma, discrimination and lack of awareness. Closing the care gap is essential to ensuring that everyone, regardless of their background or circumstances, has access to the cancer care they need. So, as in the nursing profession, we understood that our journey in healthcare is not merely about learning the theoretical aspect of nursing. It is about embracing empathy, compassion and commitment to elevating the sufferings. World Cancer Day provides us with a unique opportunity to reflect all the pivotal role we play in the lives of those affected by the cancer. Our guest speakers today will share insight into the evolving landscapes of cancer treatment, emphasizing the importance of multidisciplinary approaches. Let us recite this opportunity to engage with them. Now I cordially invite Dr. Venkateshan Balu sir, our esteemed principal, Gitam Institute of Nursing, onto the dais. I extend my hearty welcome to Dr. S.T. Rao sir, guest of honor. Sir was not there, but I welcome him on this occasion. Next, with extreme delight, I invite our chief guest, Dr. B. Gitanjali ma'am, Pro Vice Chancellor, Medical Sciences, Gitam, Visakhapatnam, onto the dais. Your presence have truly elevated the occasion and we are deeply thankful for your time and contribution which enriched the occasion, ma'am. Thank you, ma'am. On behalf of Gitam Institute of Nursing, I welcome our distinguished speakers, Dr. B. Ravishankar sir, radiation oncologist, radiation oncologist, Managing Director of Omega Cancer Hospital, onto the dais. We thank sir for accepting our invitation and gracing today's event. I extend my welcome to Dr. B. Sudharani ma'am, Professor and HOD of OBG Department, Gitam, onto the dais. We welcome you, ma'am. We are truly honored to have you as our speaker today. Thank you, ma'am. With great pleasure, I welcome Dr. Raghuvanshi sir, Surgical and Clinical Oncologist of Smart Visakhapatnam Cancer Clinic, onto the dais. We would like to express our deepest gratitude for being a beacon of inspiration and knowledge for the event, sir. Thank you very much. And I heartfully invite the teaching and non-teaching faculty and also the students of Gitam Institute of Nursing on this occasion. Let us begin this aspiring day with a prayer song. I request everyone to please stand for the prayer.
Vande Mataram, Vande Mataram, Sujalam, Sufalam, Malayaj Sheetalam, Shasya Shamalam Mataram, Vande Mataram, Shubhrajyosna Pulakitayaminim, Pullakusumita Drumadala Shobhinim, Suvasinim, Sumadhura Bhashinim, Sukhadam Varadam Mataram, Vande Mataram, Vande Mataram.
Light is a symbol of knowledge and wisdom. I request the dignitaries to come forward to commence the ceremony by lighting the lamp. Please raise as the diya has been lit. Thank you everyone. Please be seated. With great delight, I request our Chief Guest, Dr. B. Gitanjali Madam, Pro Vice Chancellor, Medical Sciences, GIMSR, Visakhapatnam, to share their thoughts on the significance of this occasion.
The dignitaries on the dais, our guest speakers, the faculty of Gitam Institute of Nursing, and dear students. I think it is a wonderful thing to be observing the World Cancer Day today. One of the reasons why this is important is because it helps us pause and look back whatever activities we have done as an institution to promote the education of the public regarding the steps they should do, A, to prevent this from coming, B, also to be able to come at the first doubt when they have any kind of cancer, if any kind of cancer or symptoms, if they feel that they may be at in the early stages. If we are able to do that as an institution, we would be doing a great service to the public. And this kind of observing these days helps us to look back and look at our activities. What have we done in prevention? What have we done in trying to educate people? And what have we done in taking the next steps towards reaching the community to inform about that? Generally what happens is to a common man, the word cancer is it brings in all kinds of things. It brings in a source of dread. It brings in what will happen to me. It brings in what will happen to my family. It brings in what will I do for the finances which are needed. So in many ways, it's very, very what shall I say? It's a huge burden on anyone, any family, and any person, no matter at what stage they are in, to face a kind of a decision which comes from clinician about this. Secondly thing will be the treatment and everything else. And therefore we need to look at this holistically. Unfortunately, as medical people, we only tend to look at the kind of treatment which is given, the treatment facilities, whether it is chemical or whether it is radiotherapy or whatever surgery, whatever modality of treatment. As an institution or as medical people, we tend to look at the treatment aspects. We do not do much for the preventive aspects as well as to promote the education that is needed to prevent, in order to prevent that. So this is the challenge which we are facing in order to make this switch. I come from a background of pharmacology, and if you look at many of the clinical trials, most of the clinical trials are, or a majority of the clinical trials will be for anti-cancer drugs. The reason is very simple. You can sell it for a great price, and therefore you'll be making a huge profit, and people will be willing to buy it. It's much more difficult to sell a lifestyle or ask people to eat healthy or exercise or be happy and do all the lifestyle changes which are required. So this is a huge mismatch in our society, especially now when we are seeking people to lead a healthier life. What is it they need to put in place? I'll leave you with an incident which stuck with me for now. It's I think about 18 years now. I have a cousin. We both grew up as sisters, and if I have somebody to call as my elder sister, it is she. And she had come visiting when I was living in Pondicherry, and she said that every now and then I have some spotting of blood. So I said, no, I think you should get it checked up. Of course, I was a professor in Gitam. So I rang up the professor of obstetrics and gynecology and said, my cousin has come and I need her to get checked up. And she said, no problem, just bring her and we'll do whatever is needed. So in the morning we were having breakfast, and I said, look, we'll go at 10 o'clock. The driver is there, the car is there, and I'll take you, we'll go together. And she said, I'll come on a holiday. I don't want to go to a hospital and have people doing tests and all that. I'll look after it later. So we were all in this holiday mood. The entire family was there and everyone was wanting to enjoy, and I thought, okay, so what? That's it. 3 years later, she has stage 3 cervical cancer. And her husband, at that time, by the time I was in Delhi, and her husband was so upset with the whole thing. She had to undergo surgery, she underwent radiotherapy. Of course, the good thing is she is still alive, she is a cancer survivor. But when I told this to the same professor of obstetrics and gynecology, he told me, what the hell were you thinking? She's somebody who's above 50 and she's saying she's having spotting from time to time, and you don't think anything comes to your mind? What were you thinking? And I've always questioned my decision at that day to allow her to have fun, with us as a family. And I put health on the back burner. At that time, we would have saved all this if I had just said, no, come with me, the car is there, driver is there, I'm taking you to the OPD, and I had taken her for a checkup. None of what had followed would have happened. So this is one of the things which we as medical professionals, as somebody who's working in a medical college, who somebody has all the resources at her fingertips, I didn't follow through it for my own person. I'll never forgive myself. And why I'm telling you this is, sometimes when people who are closest to us come with a health problem, we are like, it's okay. I don't think it's anything great. But it could be something serious, and that's the message I want to leave all of you with. All of you will have an elderly person in your house. It might be a grandmother, it might be a grandfather, it might be an aunt who might be in the age where they have to take care of their health and they may be not taking care of it adequately. So this is the story I want to leave you with. And as with all cancer stories, where there is sadness, there is also hope. And the survivors of such cancers always leave us with this message of hope. So I hope you will carry a message of hope. I hope you will carry a message of taking care of oneself on this World Cancer Day, where we need to make sure that our message reaches the people whom we ought to reach. So I once again thank both the speakers, the 3 speakers actually. The one is from our own institution. I thank all the 3 speakers for agreeing to come and talk to our nursing students. And thank you very much for being with us today. Thank you.
Thank you very much, ma'am. We'll remember your words, and we will have a hope that we will treat the cancer patients. And I request the dignitaries on the dais to felicitate our distinguished speakers. Dr. B. Sudha Rani ma'am. Dr. Raghuvanshi sir. Ma'am, thank you sir. Now it's time to start the session. I request all the dignitaries on the to be seated off to the dais. Now I call upon Mrs. Asha Purna, tutor, Gitam Institute of Nursing, to introduce the speakers.
I will leave in because I have another meeting to attend.
Thank you, madam. I feel very privileged to introduce Dr. Ravi Shankar sir. He did MBBS from Sri Devarajas Medical College in the year 1992 and did his MD from CMC Vellore, did DNB, FRCA in clinical oncology in 2007 and ECMO PDCA in 2010 and did his MRCP in medical oncology. He was the first Indian oncologist to have fellow Estreform Geneva and he did masters in his oncology in 2019 from European School of Oncology. His professional journey as radiation oncology started at Christian Cancer Center, Kakinada in 1997, later rendered his services as senior consultant radiation oncologist in Lions Cancer Hospital, Visakhapatnam, and worked as an assistant professor in Kakatiya Medical College, Warangal, and Andhra Pradesh Medical College, Visakhapatnam. He also worked as the senior consultant radiation in oncologist in Queen's NRI Hospital over 30 years. At present, he is working as chief radiation oncologist in the Omega Hospital since 2019. He participated as speaker and faculty in more than 30 international conferences. He published 15 articles in various journals. Sir, thank you for accepting our invitation and joining in this event. Please, sir, come and take this dais.
Good afternoon, everybody. Uh, it's in probably one of the first talk addressing the nursing staff and nursing students in Gitam. And really thank to all the faculty and the principal of nursing college for giving me this opportunity. Let me go through what is really happening in this cancer and what we have to know and what we have to tell our relatives and friends. So, as it was rightly said by our Gitam madam, it's a big public health problem, not only in India, across the globe. And it has a long latent period, needs a lot of infrastructure, trained staff, to invest a lot to build up in cancer hospital. And like developing countries like India faces a lot of challenges in addressing these problems. And the major risk factors, as you all know that tobacco is the major one, which probably 30% to 35% of these cancers are related to this consumption of tobacco, and our dietary habits, chronic infections, and so on and so forth. As the picture depicts, it's the incidence of the cancer is increasing, and we keep hearing something or the other about the cancer. Somebody is suffering, or somebody known to us, one of us is suffering from cancer. It's because either many of these celebrities who are cancer survivors, and they spread a lot of information and a lot of courage to all the patients, or known persons like a cricketer or a film actress. So today, if you look at the problem of this cancer in the world, is about close to 19.3 million cases that we are seeing. That's the prevalence. And if you look at the number that we are going to face in another couple of years, is going to be almost double. Are we really equipped enough for battling this disease or not, is a big challenge for low middle class income generating countries. So the theme of this World Cancer Day is close the care gap. What does it mean? So that means every individual or a cancer patient has got the right to get the best treatment. There is an inequality among the availability of the treatment across the globe, not only in India. So it is just to fill the gap, we have to build up infrastructure in most of the district hospitals or whatever. And there are certain barriers which stop us to deliver our goods. So the barrier could be gender discrimination. So we say that he is a male patient, he is the breadwinner of the family, he needs to be given the priority, not the female. So that should not be in your mind. Whether it's a female or a male, they have to be given the right treatment. And the socio-economic status. For patients, 90% of your patients who are attending cancer hospitals today are supported by the government, and the government takes care of all the needs like radiotherapy, surgery, chemotherapy, and so on and so forth. And age discrimination. Somebody says that this man is elderly man, 65 years old or 70 years old, he has nothing to do, so leave him. That should not be there in your mind. Whoever it may be, if the patient is in a condition to tolerate the treatment, he should be offered treatment. So if you look at the statistics, this is the Globacon, which takes up the information from various hospitals and registries, and they build up in data. The data shows that these are the 5 common cancers that we are tackling in our country. The first and foremost thing is the breast, followed by head and neck cancers, and then you have cervical cancer, lung cancer, and the colorectal and stomach. So what is a more worrying thing? As a oncologist, there is a age shift. Age shift in the sense, cancer was thought to be a disease of elderly people. That means those who have crossed beyond 60 years. That's so. That's what we learned 25 years ago. But today, what we are seeing is different. We are seeing younger patients getting affected with this dreadful disease. Rising numbers in India, that's also a bothering one. Late presentation, in spite of a lot of information has been percolated among the society, but still we get the patient in a stage 3 or stage 4. Unfortunately, because most of these cancers would not have a specific symptom or a sign by which you can pick up and say that this is cancer, I should manage or I should biopsy or whatever. So most of the signs and symptoms are almost similar to the disease that we day to day what we see, a benign disease. Lack of awareness. Still, I feel that more than 40-50% of the population, they may not know what is cancer, and they don't know how to come for an early detection, or they don't know what is screening, they don't know what is pap test, mammogram, all these things. So they need to be educated that these are the investigations which are very cheap, which can identify the disease at an early stage, so that you can, get rid of all the modalities, radical modalities. Maybe with the limited amount of treatment, you can come out of this problem. And the most unfortunate thing is, today we see the young patients getting affected with cancer, and the cancer disease in the young patient is going to be very aggressive. So after listening to different talks, the first thing that I always get a call is, sir, I heard your talk and I have a small lump in my breast with cancer. So don't get carried away with whatever information that you have. See the lump which is there, it could be benign 90% of the times, and it could be malignant only in 5 to 10%. So don't get frightened or don't get too much of worried about that there is a lump. So see, definitely if the lump is increasing in size or change in the dimensions, or if there is any change over the skin or something else, if you have observed, probably that's the time that you have to take an action. But if you identify a lump in a less than 30 years of age, probably I wouldn't say that 90% of the time it is benign rather than a malignant. So there are different kinds of nomenclature given to this basing on the tissue of origin. If it is arising from an epithelial cell, then we call it as a carcinoma. If it is arising from a connective tissue or a bone or whatever, then we call it as a sarcoma. If it is arising in the lymphatic channels or anything like that, it is lymphoma. So these are the risk factors. Anyhow, all of you know that tobacco is the main culprit, and added to that, if somebody is a smoker, they can have more chances of having malignancy, because alcohol per se cannot initiate the carcinogenesis. Tobacco has got the initiating process, but alcohol is a very big promoter. That means it can promote the further progression of the cancer. So excessive body weight, genetically if you are prone, if you are getting exposed to the sun, radiation, unhealthy food, all these things. And the most important thing is, as you grow old, you are prone to get cancer. That is a simple thing that you have to accept it. So same thing here, only thing is like, almost 30% of these cancers are related to tobacco and alcohol, and 30 to 35% of these cancers are related to unbalanced diet. That is where we are stuck. And the other one is a chronic infection and hormonal changes. So coming to the factors that can have influence on the carcinogenesis are environmental factors, dietary factors, lifestyle, genetically prone, or inadequate in detecting the process. So other thing is like environmental factors, like I have already told you, tobacco is the commonest one. We all know that various forms of tobacco people are exposed to, like it could be a smoking, chewing, or different varieties. And the second thing is alcohol, smoked fish, especially if you are having a red meat which is being, kebab, very dangerous, because the hemoglobin on the blood which is there in the red meat, when you burn it, it forms a carcinogenic material that can, start initiating process in the GI tract cancers. And beef consumption, because it contains a lot of fat, so if you take a lot of fat, you are prone to get bowel cancer and breast cancer also. If you have a diet which has got less fiber, then you are prone to get bowel cancer or intestinal cancer. So all these things are risk factors. We don't say that if somebody is consuming this, they are going to get. But compared to the normal individual, if somebody has got this kind of a lifestyle, they fall into a little higher risk group of category. You can say that. And occupational hazard, it's very important, because a lot of our employees, they get exposed to various chemicals in their industry. It could be benzene, cadmium, vinyl chloride, and so on. So other thing is, if they have an additional habit of having an, consuming a tobacco or something, they fall into a very high category. That's the reason, though it is called as industrial zone Visakhapatnam, a lot of these patients, they exposed to various chemicals. At the same time, they have this habit of using this tobacco and alcohol. They have a very high risk of having this cancer. There are certain viruses which can put us at a high risk for getting this cancer, like hepatitis B and C. Though we have a vaccination for hepatitis B, you can prevent it. HIV infection, AIDS complex, EBV virus, cytomegalovirus, human papillomavirus, which is very important. Persistent HPV infection can put you at high risk for getting cervical cancer. And human T-cell leukemia virus can have T-cell leukemias. So there are certain genetic factors which can also put us in high risk. But the chances of having, or if you see the hereditary or a genetic pattern, it's only 5% of your total number of cases that you see will fall into this basket. So these are the various kinds of preventions that we use, like it could be a medication. There were some trials like Relaxaban was used for preventing breast cancer, lifestyle changes, treating the infections early, undergoing a prophylactic surgery, like if somebody has been diagnosed with a BRCA splitting, vaccinations, especially for HPV and HBV virus, and screening tests. So breast cancer is very common among the women, and also it is one of the commonest cause of one of the commonest cancer that we see in the clinic. So you can detect them with regular breast self-examination, mammogram. The symptom is like you will have a small lump or a thickening or a dimpling of the skin, or somehow kind of an irritation you may have. There is always a high risk group for breast cancer, like if somebody has got in your family, like your grandmother or a mother or mother sister or father sister or grandmother sister, then you will have a little higher chance compared to a normal individual. Not that you will have breast cancer, but you will fall into a high risk group. So this is how it is. I am not going into the details of treatment because my next speaker is going to tell you all the treatment aspects. So there is always a good relation of a parity and the breast cancer. Parity means if you have your first child below 30 years, we say that there is some amount of protection that you achieve. Because when you become pregnant, there is a huge interval in your menstrual cycles. That's about 1 year, and you start giving the milk, that is a lactating period, it's about 5 to 6 months. So if you take that, on an average 1.5 to 2 years, your breast tissue is away from the influencing hormones. So that's how you get the protection for breast cancer. So that's why we say if somebody is not giving breastfeed or somebody is not becoming pregnant on her own, then we say that they fall into a high risk group for getting this breast cancer. Age at menarche and menopause. That means on an average, if you have more than 30 years of menstrual years, That means like your menarche is about 8 years or 9 years and you still menstruate beyond 50 years, then the chances of having the breast cancer is pretty high. So prior breast biopsy, diet, hormonal factors, all these things, high socio-economic status people, they will have higher chances of having the breast cancer compared to others. Like radiation, olden days, like cervical spondylosis, Hodgkin's lymphoma, somebody gets the radiation and they are prone for having a breast cancer as a second malignancy. Oral contraceptive pills, this is very important. Of course, these days we don't have a OC pill with a high dose of estrogen, but these OC pills always like they have the stimulatory effect on the ducts in the breast tissue. So that's why we have to be careful when you are using these OC pills. And the primary prevention is like you have to educate the people and they have to undergo as early as possible mammogram if they have any symptoms, or secondary prevention is like you treat them properly and try to detect like any recurrence or anything is there as early as possible. This is how the breast self-examination is done on lying position. The easiest way is when you are taking the shower or when you are standing in front of the mirror, you can see the level of your nipple, you can see the contour of the breast, and then when you are taking the shower you can just feel it. So preferably after 3 to 5 days from the time of menstrual cycles, it's always better because that's the time we expect the breast tissue will be little softer compared to the other days. So coming to the colorectal cancer, it's not so very common, but we do see a lot of patients, and there are various modalities to control the disease. Again, it has a strong relation with the family history and alcohol consumption, especially beer and smoking, low fiber containing diets and all that. So this is how it looks like as the stage of the disease progresses, it penetrates to the wall, through the walls of the colon, and it can affect the neighboring structures. That's where we will be very unhappy to do the surgeries. So like okay, so the risk factors for colorectal is diet, which has got a very high content of red meat. It could be beef or a pork or a lamb, whatever, and cooking the meat at higher temperatures like grilling and all that, as I already mentioned, and very low physical activity, smoking, heavy consumption of the alcohol. All these things put somebody at a high risk for getting this malignancy. So how do we diagnose them? So you have got two sides of colon, that is one side is the right and the other one is a left. Unfortunately, right-sided colon cancers, they will not have any kinds of symptoms or signs. Only thing is they will present with an anemia, that is a loss of low in hemoglobin with any kind of an underlying reason. So if you find somebody with anemia, probably preliminarily you should think of any helminthial infection. If that has been already covered and still patient is not picking up his hemoglobin up, then probably you should investigate for colon cancer. Whereas on the left side, could be a diarrhea, it could be a constipation or change in the bowel habit and bleeding for rectum. So these kind of symptoms can make a person or a patient to present little early compared to the right side. That's why we say that left side colon, they have a better prognosis compared to the right side colon. So it is preventable. You should have a good high fiber diet and protect yourself from alcohol and all that. Okay, coming to the prostate cancer. Prostate cancer, once upon a time it was thought to be a disease of the Western people, but today we are seeing a lot of patients, especially in India, with the prostate cancer. Way back in 25 years ago, we used to see 1 or 2 cases in a year, but today we are seeing more than 3-4 cases in a month. So the incidence is really going up. So usually one test that we always ask is a prostate cancer, prostate specific antigen. I'll show you what it is. This is how the prostate lies somewhere just below the bladder. This is is a normal prostate and this is an enlarged prostate. So enlarged prostate, it doesn't mean that it is malignancy. The most common thing is benign prostatic hypertrophy, and anything other than that could be a malignant. So how do you define? So usually they have obstructive uropathy. That means they will have obstructive symptoms. They will have difficulty in passing urine, or they will have increased frequency, or they will have the stream will be decreased. So these are the main symptoms. If you find somebody having that, probably you should consult a urologist and get him checked and see the PSA. If the PSA is grossly elevated, then probably it is a prostatic malignancy. Then he should undergo biopsy. So again, the reason or a cause for prostatic cancer we don't know, but there is a good relation, in family history of prostate cancer, like especially BRCA positive disease. Like if somebody has got ovarian cancer in the family or a breast cancer in the family, woman, the men can have a prostate cancer. This is something which we have to keep in our mind. So genes which I have already told you, BRCA1, BRCA2, diet, or even for prostate cancer, the red meat is not fairly related. Probably it is one of the risk factors. So as I mentioned already, they can have frequent urination, urinary hesitancy, nocturia, decreased force of urination, and urgent urination. So this is how you can reduce your risk. Like you eat all colored vegetables, reduce having meat, keep yourself away from all the alcohol and the tobacco. So early detection, as I already told you, PSA is the easiest way. PSA is a prostate specific antigen which will be raised. Even in infections also it is raised, but what we usually do is, if it is in the borderline, we give them a course of antibiotic and then we repeat. If still it is persistently elevated, then we do other investigations to rule out prostate cancer. And the second thing is digital rectal examination, by which you can find out whether the prostate is hard or a firm. If it is really hard and the median groove is lost, probably we are hitting a prostate cancer rather than a prostate hypertrophy. So this is what digital rectal examination in the prostate specific antigen. This is how you screen the patients for prostate. And the other important thing is that carcinoma cervix. In spite of having so much education and elevation in the socio-economic status, still the rural population who are coming to our hospital, majority of the women are suffering from carcinoma cervix. The only prevention for carcinoma cervix is just keep your personal parts hygiene. You have to maintain that hygiene in the personal parts. That's the best thing that you can do. And second thing, of course, I'll tell you the rest of the things. So risk factors are early age at having sex and frequent births, multiple sexual partners, HPV infection. HPV infection, always you must remember that it is a persistent HPV infection, always leads to cervical cancer, not just HPV infection. And the low socio-economic status, of course, smoking and all that. So you have got different parts, like one is an outer side, one is an ecto and endocervix. So that can come as an proliferative growth or an ulcerative growth or an infiltrative growth. The most common thing is a squamous cell carcinoma. Very rarely you can identify how the cervix is going to be. This is the cervix, and this is the growth spreading into the cervical and the parametrium here. So the reason why we have to know the staging is, if it is just confined to the cervix, we can just get away with a surgery. If it is spread to the other areas, then we have to give them a radiation and chemotherapy. This is how you have to plan when you're planning for cervical cancer management. So these are the symptoms like postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding. As madam said rightly, somebody who is beyond 50 years or 60 years, was attained menopause, suddenly having a kind of bleeding or a spotting or white discharge, probably that needs to be investigated. you have to keep it in your mind. That needs to be investigated. And so these are the signs like you cannot demonstrate any sign for cervical cancer. Only thing is you have to see it on a speculum and see whether the growth is involving the cervix or not. So this is actually prevention chart for the cervical cancer. Less than 21 years, usually we don't recommend. And somebody who is beyond 21 to 21 years, we use the cytology for every 3 years. And somebody who is beyond 30 up to 65, we use every 5 years HPV testing. And beyond 65 years, we usually don't encourage them for participating into pap smear test. So these are the investigations that you can do, like biopsy from the obvious growth and abdominal scan and all that, just to know where it is spread. The other one is ovarian cancer. Ovarian cancer is not so common. Usually, this is how the ovarian cancer looks like on a cut section. And these are the main symptoms. Like they can have bloating of the abdomen, distension of the abdomen, feeling full, and loss of appetite, urinary urgency, because the ovarian swelling will be pushing on the, it will be having a pressure effect on the bladder, so they will have urinary urgency, fatigue, unexplained weight loss, and all these things are the symptoms for ovarian cancer. Again, ovarian cancer, you have to use a triple testing, like you have to use a CA-125 abdominal scan and your clinical examination put together. You can say that whether the patient is having any likely to be having the ovarian cancer or not. Coming to the lung cancer, smoking, secondhand smoking, all these things are risk factors, like exposure to arsenic, cadmium, all this. And this is how the lung cancer looks like. The symptoms and signs are almost similar to any kind of lung disease like tuberculosis. So almost 90% of the times it is TB being treated like wrongly. All these patients are treated for tuberculosis compared to CA lung. So whenever if the patient is having a persistent symptoms in spite of having the treatment for tuberculosis for more than 1 or 2 months, probably we must investigate and do a biopsy and see whether there is any underlying cancer is there or not. So the cancer prevention has got like primary prevention, secondary prevention and tertiary prevention. These are the 3 areas. So primary prevention is basically early diagnosis, and the secondary prevention is early treatment and mammogram and all that. So tertiary is like intervention. So how to reduce your risk? So you are the one, you have got the switch with you. You can put your, you can turn your switch onto the low risk or a high risk. So if you adopt any of these, probably you can put yourself at a lower risk compared to the other people. So don't smoke, keep healthy weight, be safe in the sun, avoid certain substances, keep yourself protected from any kind of chemical exposure, drink less alcohol. I would say don't drink, okay? And eat good fiber diet, avoid unnecessary radiation and all that. Anyhow, you can go to net and you can get all this information. One thing is, you should have in your mind that I should put myself at a lower risk. That's the only thing. So thank you very much. It's just not that learn. At least I expect 10% of it you must study to and your.
Thank you so much, sir. You really thought very much experience-based knowledge really entitled us with so much of knowledge, and I think every student's got so much information. I know this subject is not in their 3rd semester, but they will read in the 4th semester. That time they will get more things that what are the sir said today, they will can use that thing in that time. Thank you. Now I want to invite Dr. Sudharani madam, and I am very honored to introduce her as a speaker today. Madam did her MBBS and MD from Andhra Medical College, and she worked in Iron Environment Hospital for 6 years. worked and retired as assistant professor from Andhra Medical College. Later worked in the Gayatri Medical College and professor and HOD in the OBG department. Later now work as a professor of OBG department as well as HOD in Gitam University of Medical College, Visakhapatnam. Madam was awarded as a best doctor at KGH Hospital for 2 times and received appreciation certificate for achieving 100% target for family planning at PhD level. She was trained in ultrasonography. Madam presented so many papers in national conference and published several articles. Madam is an executive member of OGSB for 7 years and member of FOGSI since 35 years. Thank you so much, ma'am, for accepting our invitation. Really, we are very much happy. We are really very much happy to get you here, ma'am.
Thank you very much for your introduction. I thank the organizers for giving me this opportunity. My topic is HPV vaccination. Why we are talking about this one? Because this is to prevent the carcinoma of the cervix. So, carcinoma of cervix is the second most carcinoma in India, in women. In 1920, about 6,40,000 were diagnosed worldwide. In that, India contributes to 1/4 of the global burden, that is 1,24,000, out of which 77,000 deaths occurred in that year. In November 2020, WHO had taken decision to eliminate cervical cancer by 2030, targeting 90% of HPV vaccine coverage of eligible girls and 70% coverage for target population with regular screening tests and appropriate management of 90% positive women with cervical lesions. What is HPV virus? This is human papilloma virus. There are many strains in that. It is the commonest viral infection of reproductive tract both in men and women, and it causes wide range of conditions and it leads to precancerous which may turn into carcinoma. 70 to 90% of HPV virus are asymptomatic and usually they resolve within 1 to 2 years. Then why are we afraid of? Only persistent high risk HPV viruses cause cancers. The main cause of cervical cancer infection is with high risk types of human papilloma virus, and that too persistent HPV infection can lead to the development of cervical cancer. Only few are low risk, many are high risk. So what cancers are caused by HPV? Previously we used to think that HPV used to cause only carcinoma of cervix, but not so. It can cause cancers both men and women. In women it causes carcinoma of the cervix, vulva, vagina, throat and anus. In the same way in men it can cause carcinoma of throat, anal canal and penile cancer. So this we can see iceberg, tip of the iceberg only we can see, but there are more to learn from inside. HPV cancers are preventable. So did you know that 50,000 of lives we can save by giving HPV vaccine to the right eligible girls every year? Risk factors, as already Dr. Ravi Shankar told: smoking, poor immune system, early sexual activity, multiple sexual partners, history of sexually transmitted infections. So prevention is primordial, primary, secondary and tertiary. And primary prevention is by vaccines. So what is primary prevention? It can be defined as action taken prior to the onset of disease, which removes the possibility that a disease will even occur. Okay, so it can be either population, that is, we have to give vaccine to all population, or high risk, means only for the high risk population. HPV vaccines are designed to prevent infection with certain types, because we have many HPV viruses strains, but only for some of them we have vaccines against them. And the vaccines are inactivated recombinant type, and they are available in 0.5 ml ampules, and it should be given intramuscularly at deltoid, and the person should be seated while giving the vaccination, and we have to observe at least for 15 minutes after giving the vaccination. This is stored between 2 to 8 degrees centigrade, and it should not be frozen, and it should be protected from light. They should be administered immediately after removal from the refrigerator. Dosage regimen is optimal is between all the girls between 9 and 15 years age, we can give vaccine for 2 doses, 0 and 6 months. But if more than 15 years but less than 26 years, 3 doses should be given, 0, 1 and 6. And more than 26 but up to 45 years, we can give 3 doses, but the woman should have the screening tests also. The vaccine is also given to boys also. Between 9 and 14, 2 doses, 15 to 26. Only in males up to 26 years only we are giving this one. HPV can be tested in girls and women, but it cannot be tested for men. So it's better to take vaccine both girls and boys at the optimum age. Vaccines available in India are bivalent, that is Cervarix. Nowadays we are not using this one. This is bivalent, that means it acts only towards 2 strains only, 16 and 18. But nowadays we are using quadrivalent, Gardasil or Cervavac. They act on 6, 11, 16 and 18. And another vaccine is there, nonavalent. This is very expensive, around 9,000. So that is, it acts against 9 varieties of HPV vaccine. So now for India, I think we can use quadrivalent vaccine because it's cheaper. Especially Cervavac we are getting for 1800 rupees only. Vaccine safety, for like any other injections, they may have redness at the site of injection or pain or swelling, okay, and mild systemic signs like headache, dizziness, myalgia, arthralgia, and sometimes gastrointestinal symptoms like nausea, vomiting and abdominal pain. HPV vaccines are safe and well tolerated and can be used in persons who are also immunocompromised or HIV infected patients. Indian government support for HPV vaccines. In Health Budget 2024, they made a decision that all girls between 9 and 14 should be given HPV vaccine free of cost in schools or in PHCs. And they are planning in giving this vaccine in 3 phases for 3 years. And they need for each phase 6 to 7 crores of doses of vaccine. So they are trying for that. For free of cost. MOH, that means Ministry of Health and Family Welfare, their target is, WHO recommends primary target population of HPV 9 to 14 years before they become sexually active. Why you are giving at 9 to 14? Because they are not yet sexually active. And achieving over 80% coverage in girls also reduces the risk of HPV infection for boys also. Vaccination of secondary target populations, that is for elderly men or elderly women, should be given if they are feasible or they do not divert resources from the vaccination of primary target population. Such situations are HPV vaccine can be given along with other vaccinations also. There is no contraindication that they should be given alone. They can be given with other this one. and it is not recommended in pregnancy. But if at all, if she has one dose of HPV vaccine, if she became pregnant, and keep the other 2 doses till delivery and give it after delivery. And this HPV vaccine also, suppose if she took HPV vaccine, there is no need for medical termination of pregnancy. There are no evidence for congenital anomalies, so she can continue the pregnancy. And this HPV vaccine can be given for lactating mothers also, as there are no adverse effects both for mother and child. So to increase vaccination, awareness and education of the general public as well as all students also is necessary. The vaccine should be cost effective and it should be safe, and long-term benefits will be noted only 15 to 20 years. So some of the questions public will ask is HPV vaccine safe? Yes, it is very safe. Millions of children are given in more than 100 countries without any effects. Does the HPV vaccine cause side effects? Not much, only like fever, pain and very rarely allergic reaction. And we have to keep the patient up to 10 to 15 minutes. Sometimes they may have giddiness for that only. Why do they need at this age? As I told you, between 9 and 14, they are not exposed to sexual this one. So it acts better in that age. Research shows that on-time vaccination provides more protection from HPV cancers than late vaccination at older age. How long will the protection from HPV vaccine last? Many of you have this one. It's almost lifelong. It acts for a long time and lasts into the adulthood. There is no indication that booster dose is not needed. Can boys get the HPV vaccine? Yes. Yes, because they also get cancers of anus, throat and penis. So they also should take the HPV vaccine to prevent these cancers. So key messages to share with parents are: HPV vaccine is cervical cancer prevention. It is safe and it provides long lasting protection, and vaccine given on time. Taken with along with other things like Tdap, flu, COVID vaccine, etc. Suppose you have taken one HPV vaccine, quadrivalent. Next time you didn't get that one. You want to take nonavalent. Can you take it or not? As far as possible, same vaccine should be taken. If it is not possible, if the previous one, if you don't know the name, or if it is not available now, you can take any HPV vaccine to complete the schedule. Should an HPV test should be done before giving the HPV vaccine for older girls? No need for this one. And vaccination is recommended even if the patient is tested for HPV positive. Okay. So HPV vaccination is cancer prevention. By vaccinating young girls before 15th birthday, we can protect them from the most cancers of the cervix and other HPV cancers. To conclude, cervical cancer is a preventable and treatable disease. Understanding its risk factors, prevention methods and treatment options is crucial for reducing its burden on society. The HPV vaccines are primary prevention at present, and hence all eligible age groups should receive the vaccination. Take home message is: HPV is very common infection of the reproductive tract in both males and females, and it causes 6 types of cancers, and vaccine is very safe. HPV vaccine is effective, but unfortunately in India not enough kids are being protected from cancers because they are not getting HPV vaccine. I hope in future all the children will be protected by giving free vaccine to them. Vaccine, is it an armor? Yes. Necessary. This is a necessary intervention for elimination. Can we rely only on vaccination? No. Along with vaccination, we had to include other methods of prevention like pap smear, screening tests and all. Amaratya, he is a Nobel Prize winner in economics. His quotation is, invest in health care, especially for the youth. Healthy mothers lead to healthy babies, which lead to healthy nation. The HPV vaccine is safe, effective and protects against cervical cancers and other cancers caused by HPV. Get informed, get screened, get vaccinated. Cancer of the cervix can be preventable and treatable if caught early. Thank you. I request all of you, all the students of nursing, both boys and girls, to get HPV vaccinated. Here it is available in our pharmacy and only 1800 for this thing. Okay? As soon as possible, I hope all of you will take the vaccination. Thank you.
Thank you, ma'am. Thank you so much for your really information. Very much that is good for us, and everyone we can keep that thing in our mind that we have to get that vaccination in our age. Okay. So now I want to introduce Dr. Raghu Vamsi sir. I am very honored to introduce him. He did his MBBS from Vinayaka Medical College, Mission Medical College, Pondicherry University in 2006. He did his MS from Kilapak Medical College, Tamil Nadu in 2010. Completed MCH from Sri Venkateswara Institute of Medical Science, SIMS University in 2014. He started his journey as a junior resident in Government Royapat Hospital in 2007 and later worked in Tata Memorial Hospital for 1 year from 2010 as a senior resident. He also worked as a senior resident in Sri Venkateswara Institute of Medical Science since 2011 and worked as an assistant professor for 1 year at the same institute. Worked as a consultant surgical oncologist in HCG Center, Vizag for 8 years. And now working as a chief surgical oncologist in Omega Cancer Hospital, Vizag since 2023 May. Sir has more than 13 years of experience in oncology units. Sir is specialized in laparoscopic pelvic oncological dissection and primary scope of interest is minimally invasive oncosurgeries. Sir has presented 2 papers and 4 posters in various conferences. He published 3 articles in various journals. Thank you so much, sir, for accepting our invitation and joining with us. I would like to invite you on the stage and take on the
Good afternoon, everyone. Thank you, sir. Good afternoon. I'm so happy to see you all so energetic even after 2 lectures. So I'll try to keep it interesting and interactive. Very, very happy to be here for the second time. I came 5 years back for a lecture here. And most importantly, thank you to the principal, faculty and the nursing department to call me here on such an important occasion. It is very exciting for me to speak to the nursing staff especially because in our daily practice what we see, I spend barely 10 minutes, 15 minutes with the patient. but once they're admitted and they're getting treatment, the nurses are the ones who spend the most time with them, and they are the ones who give me the feedback, what the patient is feeling, how they're doing. So it's very important that you people learn about cancer, you have an understanding about cancer, and so that you're able to answer well, and we all form a good team and give the best care to the patients. So today's agenda, basically I'll be already 2 lectures have gone, very nice lectures on the risk factors, prevention, screening of cancer. So I'll be concerning myself only with the treatment aspect. That is what we are all going to learn now, and you're all in your second year, third year, final year, you'll be seeing patients, and that is where you'll be applying all this information you get. So a basic introduction to what is cancer, then the types of treatments which are available. I'll be elaborating on each of them so that you basically understand. If someone asks you what is radiation therapy or what is chemotherapy, you all should be able to answer that, and I'll summarize for you to remember for a long time. So why is this so important? Why are we all so afraid, and especially people outside? What is the real worry? See, cancer incidence has increased. Today we have almost 920 lakhs patients being diagnosed every year with cancer, and that is only 1/3 of the reported incidence. See, only 3 out of 1 person is recorded. That means if we have 20 lakh patients, we're actually having 60 lakh cancer patients every year, and unfortunately it's going to increase at a rate of 13% per year. So it's going to go quite high by the time we reach 2025. Unfortunately, 1 in 9 people in India is going to have cancer. So this is something more like a pandemic which we've had, and it will come up in a big way in the coming time soon. So we should all be aware and take measures, because treatment is one aspect, but most importantly prevention has to be is the best form of cure, as we all know. So as sir has already explained, the most common cancers here in males, it is actually head and neck cancers, but individually lung, followed by mouth and prostate. In the females, it is breast cancer and cervical cancer. So what are all the treatments which we have for cancer? So there is a long history of treatment. From the 1800s we've been seeing cancers, and lots of treatments have evolved now, and these are all the armors we have in our system to fight the cancers. Though there are many of them, 3 most important things you guys should remember. Everyone knows surgery, radiation therapy and chemotherapy. These are the 3 pillars on which the treatment of cancer stands. And now we have additional treatment facilities which are helping and getting us better cure rates. So simply classified, they can be a local treatment or a systemic treatment. See, today cancer is actually a lifestyle disease. What they have found out is cancer is like anything like your diabetes or a hypertension. That means it is not just your genetic factors or bad luck that gives you cancer. Up to 60 to 70% of cancers can be controlled or prevented by making lifestyle changes. So what happens is, once you develop cancer, it is not usually like it is involving only one organ, say it's in the mouth or in the breast. It is not like it is there only at that place. It is usually a tumor is there, say 2 centimeters tumor, it means 1 million cells are there inside your body. So you'll have to treat the tumor locally and also all the cells which are there in the body. So cancer is a systemic disease to present with most of the cancers. So we have 2 forms of treatment. One is local and the other one is systemic. So local is the one where we do surgery and radiation therapy. Bone marrow transplant is also a part of local treatment. Systemic therapy is where it goes into the blood system and it kills all the cells which are there in the blood. Primarily chemotherapy. Now we have targeted immunotherapy and hormonal therapy. So we'll go a little bit into each one of them and understand how they work, so that you are aware of what are the treatments which are available, and go forward you will learn that. So surgery is the most ancient form of treatment we have always had, and not just for cancer, for any form of tumors, any problems. Surgery was always been there for a long time, from the time of BC. So what is new now that we need a surgical oncologist to treat a cancer? Why not a general surgeon? Why not other surgeons who are already there? See, cancer, as I just told you, it has become a systemic disease. It is not like previously we would say, okay, this fellow has a tumor, we'll just remove it and then send it to the medical oncologist or a radiation oncologist. They'll take care of it. That is not how it works now. So a surgical oncologist has been specifically trained to understand the disease well, so that today, as soon as the patient comes with a lump, the first treatment is not surgery. May not be surgery. Yes, it may still be surgery, but there are options like chemotherapy, there are options like radiotherapy, which may need to be given upfront. Most commonly in breast cancer and rectal cancers. Here we give, in breast cancer, we give chemotherapy upfront and then do surgery for up to 50% of the cases. And in rectal cancers, almost 90% of them come in a stage, advanced stage. So we give radiation first and then do operation. So what we call it as a multidisciplinary approach. That is not just the surgeon, but the radiation and medical oncologist, all of them work together and then give the treatment. That is why it is very important to have a surgeon who is totally involved in the treatment, and so a surgical oncology branch has developed. So it has been a 4,000-year tradition from the ancient Hindus, Sushrita, we have been doing these operations, and today we have ended up with advanced equipments like laparoscopic and robotic surgery, and we are getting very good results. So just a brief idea of how surgery has developed. So basically in the 1800s and 1900s, basic surgical standards, anesthesia had come up, and so we were able to do good surgeries. So standard surgical techniques were used, but what they understood at that point of time was the standard surgeries which was used for other lumps were not useful for cancer. Even if we do the same surgery for a normal tumor and a cancerous patient, he always had recurrence. So then they decided, okay, we'll go more radical and we'll remove the whole organ. So for breast cancer, they used to remove the breast, the underlying muscle, the axilla, everything around, all the veins surrounding it, etc. Unfortunately, by 1980, they realized that, okay, even this is not working, just removing everything also will not work. And it comes back to the same thing which I told in the beginning, cancer is a, louder? Yes, systemic disease. So it is a systemic disease which involves the cells are there at different body. So doing just bigger and bigger surgeries is not helping. So that is what they found out, and multimodality treatment came in. And then research has now found that in breast cancer surgery, I operate almost, say if I operate 100 patients, up to 60% of them I'm able to save their breasts. That is, they're coming at an early stage, I don't remove the whole. Along with the breast conservative surgery, additional radiotherapy, chemotherapy are given, and we are getting the same results as when we remove the whole breast. So that is how it has improved, and presently now molecular biology and genetic biology, genetics has made big advances, and now in future we'll be even planning treatments based on this. A simple example is in breast cancer, where you do a IHC known as immunohistochemistry, where if it is a triple negative breast cancer, we give chemotherapy first for 6 cycles and then only we operate to see the response. So that is how the whole treatment has changed. So the 3 principles or objectives of surgery: always operate only when you know you can remove the whole tumor. Never operate when you are going to leave behind some tissue. Cancer has to be removed in toto with good margins. That is known as tumor-free margins or R0 resection. Preserve function as much as possible. Just like I told you now, for say breast, we are preserving the breast tissue. Similarly, in the throat, for a laryngeal cancer, previously we used to operate and remove the whole larynx, total laryngectomy. We have larynx preservation methods. Similarly, bladder preservation techniques, so on and so forth. For different areas, we are trying to preserve function as much as possible, because we have additional treatments like radiation and chemotherapy, with which we are able to get the same results. Cosmesis is important, but not the most important priority. So that is also taken care of today with the help of laparoscopic surgery or robotic surgery, and even in breast, which I will be telling in detail. Because I cannot cover most of the cancers, I'll just give you a brief of how the breast cancer treatment has developed. So as you go from above to below, it is the most radical surgery. Previously it used to be radical mastectomy, then it became a modified radical. Now we are nipple sparing, skin sparing, breast conservation, oncoplastic breast surgery. That means only a part of the breast is removed, and the fat in the breast is used to reconstruct the breast to look like normal tissue. And in some situations where we may have to remove the whole breast, but we still do reconstruction. And sentinel lymph node biopsy. See, the surgery for breast includes both the removal of the breast tumor and also removing the lymph nodes in the axilla. So that used to be quite a morbid situation, where up to 10% of the patients will develop lymphedema, that is the swelling of the upper limb on the side of axillary dissection. So to avoid that, we have found this sentinel lymph node biopsy, where injection is given. I will describe that in detail. So I'll just show you some images which unfortunately you wouldn't have seen, but we get almost 60% of our patients in this stage, that is stage 3, with advanced big tumors. Unfortunately, we end up removing the whole tumor. Here we will not have much of an option. Still, they have to undergo radiotherapy and chemotherapy, but we cannot conserve the breast. Here you can see breast reconstruction options for these patients also, where we have removed the whole breast, but still we have put a flap. For this lady, a breast conservation surgery, a big tumor, but still we could reconstruct with a flap from the abdomen. Similarly, the cosmesis is quite good. The muzzle is taken from the back and put it wherever we have removed the whole tumor. Where a large tumor is removed and end of the day the breast looks not so good or ugly, then some form of cosmetic surgery can be done to make it look good. And these are the cases where you have a very early breast cancer, so you need not do a reconstruction. The breasts almost look very similar, and we are able to do what is known as a breast conservative surgery. So that is the advance we have done, we have come to today. And the sentinel lymph node biopsy, which I was speaking about, these are the lymph nodes where the tumor spreads. So we give a dye in this area, and then we remove these lymph nodes and check for the color. Also, a gamma camera is used. All this increases the accuracy of identifying the metastatic lymph nodes. Metastatic means the tumor which goes from the primary in the breast to the lymph nodes in the axilla. That's metastasis. So we identify those and we don't remove the whole axillary lymph nodes, thus avoiding the complication. So this is about breast and the advances. Today we are into the age of minimally invasive surgery and robotic surgery, where you have this machine, okay, one known as a Da Vinci robot. It's still a person which is handling the machine, but it's a big advance in software where you can sit here and operate, and you have people helping you, and we're able to do surgeries in the abdomen for many cancers. So it has its uses and is helping remove complex tumors in a very good way. So these are the advances in surgery. So we need to know is no matter how advanced the surgery, the surgical oncologist remains the pillar who has to decide what kind of surgery is best for the patient. And as I told you, the main objective is to clear the whole disease. Another important role a surgeon has is the chance of preventing cancer. There are some conditions where you have a genetic abnormality, that is a mutation, say BRCA1, BRCA2. If this mutation is present in a lady, she has a 80% chance of developing a breast cancer and a 60% chance of developing an ovarian cancer. So before developing that, we can do a mastectomy and an oophorectomy, which will totally eradicate the chance of breast cancer. And that is what, if you know, Angelina Jolie underwent. Similarly, you have MEN2, that is a red oncogene genetic mutation. There you have a chance of developing a medullary thyroid cancer. So a thyroidectomy will prevent the cancer. Similarly, with an FAP, you remove the whole total colon, so the patient does not develop cancer. See, as soon as a patient develops a cancer, no surgeon, no oncologist can give them a 100% guarantee that their cancer will be cured. Even with stage 1 disease, we can give a guarantee of up to 90-95%. Okay, so it is always imperative that we are able to avoid the cancer or prevent the cancer from developing. In these patients, if we are able to identify early, we can as well avoid it and they can have a normal lifestyle. Sometimes we can identify precancerous conditions, as you can see a small white patch here. If you leave it alone, 5 years to 7 years from then, it will develop into a cancer. So that can be removed, and in that way also a cancer can be prevented. So this is the important role of surgery in prevention and treatment of cancer. Next we come to radiation. Radiation is also a very old form of treatment which has been there for more than 70 years now. So it is common for general public not to understand what it is. So does anyone have an idea what is radiation therapy? Anyone wants to define what is radiation? No one? Not yet? Okay, so it's common, patient coming and asking, sir, radiation, oh it is light, oh it is current, will it pain, will it burn? So they're always afraid when we tell them it is radiation. They just want surgery and they just want to go away. So it is time that you people who interact with the patient most, you understand what is radiation. See, all these light, sound, radio, it's all basically a form of energy. Okay, here it is, energy can be either non-ionizing or an ionizing radiation. See, all our electric trains, AC power, the monitors, the TV, cell phones, these are all at a different frequency. The higher the frequency, it becomes an ionizing radiation which we use in our X-rays. Okay, and then that is the electrons there. Similarly, you have gamma rays and beta rays, which are even stronger rays. So this is basically the basis of treatment of radiation. So there is a machine which produces those rays and it will attack the cancer cells. So we are using high energy rays to kill cancer cells. That is what is radiation. There is nothing to worry. Patient does not feel anything. There is no pain. That is how it works. It has two methods of action. One is indirect route, where the water in our body is broken, free radicals are formed, they attack the cells and cause DNA damage. The direct route is the radiation rays itself directly cause DNA damage, as a result killing the cells. So this is how radiation works and kills the cancer cells. It is a form of a local treatment only. It does not affect the cells in the entire body. Now, unfortunately, when we give radiation, I will show you in the next slides, normal tissues beside the radiation field, as they call it, they are also affected. And like when we give radiation, it goes through the skin becomes black, it looks like it has burned. Then patients develop, depending on the site of involvement, if it's in the throat, they may not be able to eat. If it's in the abdomen, they'll have loose motions, nausea, etc. These are some side effects which are inevitable. So this is the machine which we use. I'm not sure if you guys have seen the CT scan here, but this is something like a bigger CT scan. Okay, this is the latest machine, TrueBeam, which is used for giving radiation. So how have we advanced? See, previously, before the machine which I showed you is the latest machine. Previously, we used to have what is called as a core machine. It used to be just like a stretcher. So we used to treat it just like a block. If the patient is sleeping, if this is the area to treat, we used to treat the whole area. So a lot of normal tissue also used to get radiated. They used to have a lot of complications. Today we have started, we have crossed even 2D plans and 3D conformal lines. So exact dimensions of the tumor are identified and accordingly the dose of radiation is given. And even more advanced is, even more specific is IMRT. These are all advanced treatments in radiation. This is what I was speaking about. This is the tumor which we have here, but see the field of treatment. We have treated the whole face, or as you can see. With the 3D imaging, we have reduced some part. Now with IMRT, we have spared a lot of normal tissue, thereby reducing the complications. So that is how technology has advanced. We are able to get better cure rates with lesser complications. So this is how a patient is kept in the machine. What is known as a cast is put so that the patient doesn't move and the tumor is treated properly. We image the tumor, what is called as contouring. Then we plan how much treatment has to be given and give a margin of 1 to 2 centimeters, and the treatment is administered. So that is radiation. Next we come to chemotherapy. This I think you guys should be knowing. Ever heard of chemotherapy? What is it? Very easy, no? I wrote it there. So chemotherapy is what we're all dealing with, and we'll all be dealing with, you'll be dealing with directly with your hands, because you'll be giving the nursing care to all these patients. It's just like any form of treatment. It is an intravenous form of treatment. Almost 90% of them, 95% of them. There are also chemotherapy tablets, but basically it is an IV drug, intravenous drug, which is given to kill cancer cells. What is chemotherapy? It is, for you to understand, simply 1,000 times more strong antibiotic. You guys are aware of antibiotics, right? So just like antibiotics, this is 1,000 times more strong. It is formed from chemicals and also from plants. So we have found various chemical compounds which work. We have also found drugs from plants, and these are all used in different cancers. Unfortunately, as I said in the first few slides, it is a systemic therapy. When it gets into the blood, it affects all the cells. The objective is also to kill all these cancer cells in the body. Unfortunately, normal cells also get affected, and it is toxic there. And hence you have a little bit more side effects, but today with the improved drugs which we have, we are able to control the side effects quite well, like nausea, vomiting, hair loss, diarrhea, etc. Unfortunately, all cancer treatments will have some form of side effect. Even with surgery, you will have some side effects, radiation, chemotherapy. But that is the price we have to pay to get ourselves cured from cancer. So how does this work? It affects at 4 levels. It prevents blood vessel growth, stops the cell division and the replication process by attacking the DNA. It causes spontaneous cell death and creates a non-dividing cell by altering its cellular structure. In all these mechanisms, the drug which are giving, there are lots, almost 100 different types of classes of chemotherapy drugs are there. They act by these mechanisms and kill the cancer cells. Just like antibiotics, we also have a protocol and a system in which we give. That is how the doctor prescribes you the system. The drugs are mixed in the IV bags and administered as per the protocol which is given. They're usually, see, whenever we give any toxic form of treatment, as I already told you, the normal cells also. So if you keep on giving this toxic treatment continuously, the normal cells will not recover. So all chemotherapy will have a protocol where they given, lower doses are given weekly, higher doses are given once in 3 weeks. So once you give it today, again they'll come back on day 21. In these 20 days, the normal cells will recover. So that is the objective how we give this treatment. So these are the basic 3 pillars of cancer treatment. Now we have advanced treatment. Okay, chemotherapy is killing all cells. What else can we do now? So now we have developed what is known as a targeted therapy. This one acts on specific molecular targets that are associated with cancer. A simple diagram for you to understand, this is a normal cell, it does not have any targets. The cancer cell has these receptors. On these receptors, the drug will go and kill the cell. Sometimes the cancer cell and a normal cell may both have the receptors, but here what happens, most of the time the cancer cells has more number of receptors and it has a higher likelihood of getting killed. So these are various drugs which are there for various cancers, as you can see here, leukemias, lung, pancreas, lots of drugs have come which have various uses, be it after surgery or after radiation or in the advanced metastatic setting, that is where the tumor has spread from the organ, be it breast, to other places. Another form of treatment is a hormonal therapy. We all know what are hormones, right? Yes? Good. So it's easy. So there are some types of cancer depend on the hormones for their growth, like breast and prostate. These are the 2 most cancers which depend on the hormones. Breast depends on which hormone? Sir just told. Yes, estrogen. So similarly, prostate, it's an easy guess. Louder. Yes, testosterone. So these are the hormones which we need to block. So we have drugs, see the receptors are there. This is the cancer cell. If it has the receptors for these hormones, then we can give drugs which will block this and that will inhibit the cell growth. In some cancer cells, the receptors will be negative. In those conditions, we cannot use. So in breast cancer, up to 66 to 70% of them will have a hormone receptor positive status. In those cases, we can give this drug and they will have benefit. Prostate, all cancers will have the receptors and there also we give these hormonal therapy. So next and the latest form of treatment which we are trying now and is actually coming to place in the last 3 years, it has developed leaps and bounds, that is immunotherapy. So what we have found is that cancer is basically a disease where it beats our immune system. So if we can find which will activate our immune system and attack the cancer cells, probably the complications and toxicity of treatments can be reduced. So that is how this works. It is a form of a biological therapy. It boosts our body's natural defenses to fight cancer and uses stuff like antibodies. We give a drug which induces the antibodies inside our body and that will go and directly attack the cancer cells. Sometimes we even give a carrier. Sometimes a virus is made which is injected into the body that carries the antibody and places it on the cancer cells, thereby resulting in death of the cancer cells. It is a developing science and already past 3 years there have been a lot of growth and lots of drugs have come in this, and it is very useful for some type of cancers where chemotherapy doesn't work, like melanoma, which is a type of a skin cancer. Another very important form of treatment today and the only hope for patients with blood cancer is what is known as bone marrow transplant. Okay, as we have seen, see, blood cancer is the blood cells which are produced from our bone marrow, there is a derangement there, either the cells are not produced or abnormal cells are produced, thereby causing the patient to have lots of symptoms and ultimately death. So here we can give chemotherapy, but once all these cells are dying, there is nothing else, it results in the patient becoming very weak and he is unable to recover. So bone marrow transplant is a form where after killing the cells, we give some more cells, either his own, that is autologous, or from outside, where that is injected into the patient, and that slowly again develops his marrow and again he regains those cells. So this is an advanced form of therapy which is very much useful for blood cancers. So those are all the treatments in the first slide which I showed you, various form of treatments which we have covered in detail. I hope you have a good understanding of all of them. So now we have gone to experimental therapies which are developing. So there is nanotechnology therapy, they are sending small nanoparticles through it which will go and target the cancer cells and thereby kill them. Therapy is one method where gene which is defective and in some form or the way try to eradicate that gene or replace it with something else. Molecular target therapy is a form of immunotherapy, as I just told you. That is the advancement of immunotherapy. Molecular targeting means it is just the genetics of the disease. We are understanding the genetics of the disease more and more. Each disease, suppose breast has almost 100 molecular subtypes of cancer. So it is not just one breast cancer. Even in breast cancer, there are 100 subtypes. So once we understand all these subtypes, we can try to target one or each of them so that we get better results. The radiation which I told you already, which is basically based on electrons and gamma rays. Now we have what is known as a proton beam radiation, which is even more advanced, and it has some applications, especially in children. In children with brain tumors, this has been found to be very useful. So these are all coming up in a big way and helping us in treating cancer. So I think I've spoken a lot. Can someone summarize now? So I'll do it for you. So let us understand, it's a very simple thing. Cancer has three main pillars of treatment. First thing is surgery. It is the cornerstone for all solid cancers. Solid cancer means any organ in your body, starting from your mouth, brain, mouth, throat, thyroid, lungs, esophagus, stomach, pancreas, liver, colon, rectum. All these are solid areas. A cancer which occurs in any of these organs, as long as you are able to do surgery, that is the best form of treatment. Okay, that means it is at an early stage and it is very much curable. Today we have come from a advanced, radical surgeries where suppose if you have a tumor on the hand, we used to remove the whole limb, giving chemotherapy, we are using the size of the hand, preserving limb. So we are focusing on the quality of life and trying, because patients are living for longer duration. Previously, a cancer patient used to die say in 3 years, maybe 2 years or so. Now patients are living for 10 years or 20 years. So we are objective. Our objective is not just to cure the cancer and also give them a good quality of life so that they have a good living after the cure of cancer. In many patients, unfortunately, only surgery is enough for only 20 to 30% of them. Along with surgery, as I already discussed, multimodality therapy, that is radiation, chemotherapy, targeted therapy, immunotherapy. These are all added in addition to improve the chance of cure so that he doesn't get the cancer back. So that is multimodality therapy. Only surgery is not enough. Up to 40-50% of the patients require surgery, chemotherapy and radiotherapy. Radiation, as we discussed, is the second important pillar. It is given in three forms. One is the radical treatment. Radical means it is the only form of treatment given for them and that will cure the cancer. As I initially spoken about her sister, stage 3 cervical cancer, there usually only radiation is given and that is curative. Even in Sonia Gandhi had advanced cervical cancer, she underwent radiation therapy and she is cured. So that is called a radical radiation therapy. Adjuvant is when it is given after surgery. Sometimes you do surgery and the disease has some features where the chance of recurrence is high. That is when you also give radiation so that it doesn't recur. Even chemotherapy may be added. Neoadjuvant is, as I told you, in rectal cancer. Rectal cancer where the disease is big and the operation we may not be able to remove the disease completely. We give neoadjuvant, that is before surgery, radiation. It reduces the tumor size and we are able to do the organ preserving surgeries. Chemotherapy also has same roles as in radiation. More importantly, it is the only form of cure which we have for blood cancers. For all blood cancers, chemotherapy and bone marrow transplant, it is the basic and the foundation of treatment. So multidisciplinary treatment is the gold standard, and immunotherapy today, it is developing in such a big way that precise therapy and personalized therapy for cancer patients. As I told you, breast cancers, there are hundreds of them. There are 100 types of breast cancer, you cannot give the same treatment for all of them. So we are trying to identify what are the differences in them and give a specialized treatment for each of them. So all said and done, no matter how good the treatment is, no matter how good a surgical oncologist I am, it is always the best form of treatment is prevention. So remember these, which have been told already in 2 sessions, and I hope you understood good enough that you can explain it to all your seniors and juniors and your members. And if you have any questions, please ask. Thank you.
Thank you so much, sir, for your really so much motivating words and so much knowledgeable words that keep us getting so much knowledge. And when you are really representing your sites and all those things, I got my previous knowledge and previous experience when what I have seen and what I have saw in my nursing. Okay, now I want to hand over this dais to Padma.
Thank you very much, sir, for the lovely sessions. Extend my heartfelt thanks to all the resource persons. Really, the information was very. The information was whatever the sessions we had. That is very expertized sessions we had, and we are having exercise sessions. And now the session is interaction session will be there. Let us open the floor for the students to raise the questions. So students can ask any questions. So if they are having any doubts and all, they can have an interaction session with our experts. So is that anyone want to ask any doubt? Yes?
All very clear.
Yes, sir. It's very clear. Okay. So now they are very experts in the field of oncology, I think so. Uba? Uba want to ask? Yeah, I think so he is having a doubt in his mind. No, sir, always he will be carrying the doubts in his brain and walking. That is what.
Good afternoon, sir. My question was, is it possible for a woman who is, because in the previous slide, there is one of the breasts is already removed. So my question was, is it possible for a woman to go surgery where 2 breasts are removed and the person still survive? Okay, my question was, like in your previous slide, there's a woman who went under operation through breast cancer. One of the breasts was already removed. So I was having in mind that you cannot live without your 2 breasts. So when I see this one removed, so I was doubting, is it possible that somebody can live when you don't have any as a female?
So breast is not an essential organ in the sense that yes, it has a function. The primary function of breast is for feeding. Okay. So most of these ladies, yeah, they do come after childbirth and after completion. For the younger people, if we have to remove both the breasts, there is no other option. But they can live. Life is not affected just by removal of the breast. The life is affected by the cancer, the stage of the cancer, the biology of the cancer, how aggressive it is. So as I showed you, most of them are single site. There are some patients who have this BRCA positive. I showed you initially where I can do a mastectomy. BRCA1 and BRCA2 are genes which affect, mutation of which results in breast cancer. So if a patient has these mutations, even though they develop one cancer on one side of the breast, we actually have to remove both. Today we have developed very good reconstructive procedures where both breasts can be reconstructed, but that is primarily for a cosmetic purpose. Functionally, of course, they may have children if they are young and they didn't have children, they can have children at a later date. But basically the whole point is to save their life, and for that they'll have to sacrifice their best if required.
Thank you, sir. Thank you for clearing the doubt. I would like to express our gratitude to our distinguished guest speaker for sharing their expertise with us today. May this gathering be stepping stone towards a future where cancer is no longer cause for despair, but a challenge that every healthcare professionals are well equipped to face ahead. So we'll take this knowledge into our profession and we will be definitely putting into our practice, sir. Thank you very much. And a small announcement, the Omega Hospital have given a coupons. So those who are above 35 years or 30 years, they can go for the mammography test with a concession. Okay, so those who are willing, they can take these coupons above 35 years. Now I would like to invite Mrs. Asha Purna, tutor at Gitam Institute of Nursing, to propose the oath of thanks.
Good afternoon all. Good afternoon who all are present here, and thank you madam. Myself Asapurna, MSc Nursing tutor, standing here today. I am grateful to express my heartfelt thanks who made this event possible. First, I would like to thank Gitam management who have always supported for our initiatives and encouraged striving for excellence. I would like to thank our Pro Vice Chancellor Madam Dr. Gitanjali B for her gracious presence in this event, who have been our guiding light and imparting wisdom and knowledge to us and nurturing our talents. I would like to thank our Dean Sir S.P. Rao for his presence and continuous support and guidance. I would like to thank our Principal Sir Dr. Venkatasan Balu for encouraging us in conducting and making this program successful. I extend my gratitude to all the resource person, Dr. Ravi Shankar Sir, Dr. Sudharani Madam and Dr. Ravi Vamsi Sir, who all taken their time of their busy schedule to grace this occasion with their presence. Your presence has added an extra spark to this event and made it even more special. Finally, I would like to thank all the faculty and students for your continuous support and participation for making this event a grand success. In conclusion, I would like to say this event would not have been possible without support and hard work of non-teaching, hospitality and technical department. On behalf of GIN, I would like to express my sincere thanks to all of you. Thank you once again.
Thank you, Asha. As we wrap up this wonderful event, let us close it on a patriotic song. So please stand up with me for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे